Hello. Dr. Sreenivasan? Dr. Sreenivasan, ma'am? Can you hear me?
Yes, I'm here.
We'll just wait for 2 minutes to start.
Definitely. I just hope I'm audible.
Yes, you are audible and visible.
Oh,
Well, after 2 minutes, we'll start.
sure.
Okay, thank you. So, can you hear me?
Sir.
Am I audible?
Yes, sir. Yes, sir. You're audible, sir.
Okay. Then we can start.
Yes.
Good evening, friends. Welcome you all to today's webinar, which is basically on a fundamental topic on physiology, that is basics of nerve conduction study. Very often we advise studies like NCS, EMG for diagnosis of different traumatic and non-traumatic neuromuscular disorders. And many times we rely on the reports generated by the technician. So we should have fundamental knowledge on the procedure, the assessment method, and interpretation of these results. Today, we have with us Dr. Aarthika Sreenivasan. She is Assistant Professor in Physiology at NGM Medical College, Navi, Mumbai. She has done her fellowship in clinical neurophysiology from Bombay Hospital. She has special interest on traumatic neuropathy. Without much wasting of time, I invite Dr. Aarthika Sreenivasan, ma'am, for presenting a talk on basics of nerve conduction study. Welcome, ma'am, for this webinar. Over to you.
Thank you so much, sir. Before I begin, I'd just like to thank the organizers and the office bearers of IAPMR for this opportunity. And of course, my colleagues at my institution, Dr. Manisha and Dr. Weber, both from the PMR department. Shall I share my screen?
Yes, please.
It says disabled for me.
The slides not visible.
So it says host disabled participants screens sharing.
Saurabh,
Yes, sir.
Arun, can you make ma'am as co-host for this webinar? She is not able to share her slides.
Yes, sir. 1 minute, sir. 1 minute.
Arun, you are the host. Sir, wait a minute, sir. Hello, ma'am. Hello, ma'am. Is it visible right now?
Yes, I can. Yes, I can. Thank you so much. Is it visible to everyone?
Yes, this is it's well visible and audible. Please go ahead.
Okay. So today I shall be talking on the basics of nerve conduction study, elaborating on the following points. The first one, basic principle of a nerve conduction study, the techniques of performing a nerve conduction study, what are the components of an NCS, how do you analyze or interpret a NCS report, what are the uses of a nerve conduction study, and what is the need for other electrodiagnostic tests other than a nerve conduction study. So what is the basic principle of a nerve conduction study? So when a peripheral nerve is electrically stimulated, it causes depolarization, which results in the generation of nerve fiber action potentials. These action potentials are then transmitted along the nerve fiber and is picked up by recording surface electrodes. In other words, the potentials which are recorded during a nerve conduction study are the extracellular recordings of intracellular events either occurring in the sensory or the motor fibers. And the process of transmission of this intracellular electrical potential through the extracellular fluid and tissue is what we call volume conduction. So it is this volume conduction which is basically responsible for the characteristic biphasic or triphasic responses that we see during a nerve conduction study. Just give me a second. So what happens is when the nerve is stimulated, the action potential that is generated starts traveling towards the recording electrode, and the recording electrode picks up this action potential as a downgoing or a positive peak. As the action potential reaches the recording electrode, there is an upward or a negative deflection of this, and as it moves away, it is once again picked up as a positive or a downgoing deflection. This is a characteristic triphasic response that we see in cases of a snap or a sensory nerve potential. Now, as against this, in a motor nerve potential, what happens? In a motor nerve potential, what happens is the site of generation of action potential, that is the motor end plate, is right under the active recording electrode, which is placed on the muscle belly itself. As a result of this, there is no downgoing or positive peak, and you see a characteristic biphasic response in a CMAP, which first composes of the upgoing or negative peak as the action potential is generated right under the recording electrode, and as the action potential trails away, the deflection goes downwards or positive. So it is a neurophysiological convention that downgoing is positive and upgoing is negative. So this is the basic principle of what happens in a nerve conduction study. Now, what are the techniques of nerve conduction study? That obviously will depend upon which nerve you're assessing. So depending upon the nerve you're assessing, the placement of your active and reference recording electrodes, where the stimulator is placed, will be dependent on that. And that can be obtained in any standard textbook. But what I'd like to stress today are a few points which are common to any potential that you want to record and is very important from a practical point of view. So the first one being the filter settings. So what we expect from a nerve conduction EMG machine is to display the amplified bioelectrical potential of interest. But what happens is, in addition to the potential we are recording, there will be patient movement which hampers in the recording. There will be ambient electrical noise in the surrounding due to other equipments in the same room, due to your AC connection to the tube light fans. All of this will come into the recording that you're trying to get. To prevent this, you have to give your machine a bandwidth in which it can record the potential under study. In other words, you have to put in a filter setting which will include only the desired frequencies and exclude all the undesired frequencies. So for every potential that you want to record, whether it is a sensory potential, whether it is a motor potential, or whether it is a needle EMG, you have to have a correct high frequency filter. By this, I mean that any frequency which is above this level will be cut off by the machine, and a low frequency filter. So any frequency which is below this will be cut off by the machine. Now, why is the knowledge of this filter setting so important? Because every potential that you record should be obtained with standardized filter settings and should be compared to normative data, which is also obtained with the same filter settings. Now let's see what happens if we play around with this filter setting. So this is a picture which I've taken from the book EMG Simplified, and you can see 3 traces. In all 3 traces, the low filter setting has been kept constant at 3 Hz. And the high filter setting has been reduced from 3 kilohertz in the first trace to 1 kilohertz in the second trace, and finally to 300 Hz in the third trace. Now, what happens is, as you reduce the high filter settings, the high frequency waves are left out. So the fast conducting fibers, the potentials generated by the fast conducting fibers are left out, as a result of which the potential that you record will have an increase in the latency and drop in amplitude, because certain fibers have been left out from contributing to this potential. So unless you have an appropriate filter setting, the potential that you record will be wrong in both in terms of latency as well as amplitude. Now from filter, I'd like to introduce another term which is called the sensitivity or the gain. So sensitivity or the gain is the setting on the vertical axis which we use to display the waveform, and it is the change in amplitude corresponding to one vertical division. So when you want to record small amplitude waveforms like the snaps, the sensitivity has to be set in microvolts. As against this, when you're measuring more robust waveforms or large amplitude waveforms like the CMAPs, the sensitivity has to be kept in millivolts. Now, if there is a technical error in this setting, this is what happens. So this is a radial snap recording. This is the correct setting of the gain or sensitivity in microvolts for a snap. Now, maintaining everything else as the same, if I change only the gain to a millivolt, the same snap will not be visible on your computer or your machine screen, even though it is really present, and you're going to give your patient a wrong report of an absent snap. So checking your gain is very important. So coming to the gain, coming from the gain which is on the y-axis, let's move on to what we see on the x-axis, and that is what we call as sweep. So the setting on the horizontal axis, which is for the time measurement with respect to the waveform, is what we call the sweep, and sweep allows for the early easy analysis of the waveform. So now the first figure shows the snap which is recorded with an optimum sweep. of 2 milliseconds. Now, if I reduce the sweep from 2 milliseconds to say 500 microseconds, as seen in the second figure, you can see that the same snap looks played out or dispersed. And if I now change it from 2 milliseconds to a long sweep of 5 milliseconds, so I'm increasing the sweep, the same snap becomes crowded in the extreme left corner. And if I keep increasing the sweep, the snap will disappear away from the screen. So again, if you need to see your potential and analyze it, your sweep also should be optimum. Now let's come to what are the basic components of a nerve conduction study. The first one is the sensory nerve conduction study. Second is the motor. You have the mixed. In addition, you have some things that we call the F waves and the H reflex. So in a sensory nerve conduction study, it is the sensory nerve which is stimulated and the recording electrodes are also placed on the nerve under study. So the response that we pick up is composed of the nerve fiber action potentials, and hence it is called the sensory nerve action potentials, commonly called as the SNAP. As against this, in a motor nerve conduction study, we stimulate the motor nerve, but the recording electrodes are placed on the muscle. So it's placed in a belly tendon montage on the muscle. And the potential that we record is composed of the muscle fiber action potentials. And hence what we record is the compound muscle action potential, or what is commonly called as the CMAP. So this is the basic difference between a SNAP and the CMAP. Let's discuss the SNAP now. So the SNAP is the summated action potential which is recorded from all the fastest conducting sensory nerve fibers. This is the settings that you have to put in your machine to get a SNAP. So whichever technique you're following will have all these parameters and the normative data which has been obtained based on these parameters. So make sure you follow the same. Now, once you measure the SNAP, what are the parameters that you look into, or how do you place your markers? So marker 1 is placed on the onset of the upward deflection from the baseline. So this is marker 1. Marker 2 is placed on the highest point of the upward deflection. Marker 3 is placed on the lowest point of the downward deflection. Marker 1 gives me the onset latency. Between 1 to 2 is the base to peak amplitude. Between 2 to 3 is the peak to peak amplitude. Now, in addition, I can put in the distance between my stimulating and recording electrodes, and the machine will compute the conduction velocity of that sensory nerve for me. So these are the parameters that I can assess in a SNAP: the latency, the amplitude, and the conduction velocity. So what does the onset latency tell me? The onset latency tells me the time taken by the nerve to conduct from the stimulating electrode to the recording electrode. So if it is normal, it tells me that segment of the nerve is conducting normally. Now, if the onset latency is prolonged, then it tells me that conduction along that segment is slowed. Or in other words, there could be focal demyelination which is occurring in that segment. Now, the conduction velocity is also a function of the onset latency. So because velocity is distance upon time, so if I enter the distance between my stimulating and recording electrode, and I put in, I know the time taken from the onset latency, so then it will compute the conduction velocity. So now let's look at this table. The table in the first line shows me the nerve that is stimulated is the right median. So the right median snap is recorded from the index finger, by stimulating the index finger and recording at the wrist. And this is showing me a prolonged onset latency and a slowed conduction velocity. As a comparison, I have shown the ulnar nerve recording from the little finger, which is absolutely normal. So what do I infer from this? So it tells me that I have a right median sensory neuropathy because I'm studying the sensory fibers. Because the latency is prolonged and the conduction velocity is slowed, I can probably say that the etiology is focal demyelination, and the site of involvement is between my wrist and the finger, so most likely to be in the palm area. And if I correlate this with the patient's symptoms, the patient has tingling in the lateral 3 fingers, if she has morning stiffness, then this is more likely to be a case of carpal tunnel syndrome. So from the latency, let's go to see what the amplitude of the snap tells us. So the amplitude is dependent upon how many fibers are contributing to that action potential. In other words, how many functional axons are there in that nerve fiber. So accordingly, the snap amplitude may be normal. It may be low if there are loss of axons, or if there is no axon, then it can also be a no response for that snap. This is the same table. Now I have also taken the left median nerve. So the right median nerve showed both the right and left median nerve show prolonged latencies and slowed conduction velocities. So now we know that there are both right and left median sensory neuropathies, both likely to be focal demyelination in the same segment. In addition, if you see the amplitude of the left median is low. It's just 5 microvolts as compared to the right, which is 15 microvolts. In other words, the left median nerve, in addition, also has axon loss. So this is a sign of a poor prognosis. So now I can tell the patient that yes, you have bilateral CTS, but the left side is less likely to recover as compared to the right side because the left nerve has gone into axon loss already. So this is the importance of the amplitude. One special thing about the snaps is, now because you're stimulating the nerve, once you stimulate the nerve, the action potential can transmit in both directions from the point of stimulation. So a snap can be recorded either proximal to your site of stimulation or distal to your site of stimulation. And accordingly, you have two techniques of measuring a snap. If it is measured proximal to the site of stimulation, it follows the direction of physiological nerve conduction, that is from the periphery towards the center, and hence it is known as an orthodromic snap. Whereas if you measure distal to the point of stimulation, it is known as an antidromic snap. Both these techniques are right, but both of them have certain inherent differences, which I have shown in this table below. Why is it important to know which technique you're following? Is because you should refer to the normative data of that technique, and I'll show you why. This is the right median snap, the first trace recorded from the index finger by the orthodromic technique. This is the right median snap, same finger recorded by the antidromic technique. And you can see the difference in the amplitude. The orthodromic technique, the amplitude is around 12 microvolts, which changes to 42 microvolts just by changing the technique of recording. So unless you're referring to normative data, which is the same as the technique you're using, you're going to give patients wrong reports. Okay. From the snap, we move on to the CMAP. So as we saw that the CMAP is the summated action potentials recorded from the muscle fibers of the muscle under study. These are the acquisition parameters which have to be set into your machine. This is available in any standard neurophysiology textbook. Okay, so now the basic difference between a SNAP and a CMAP is the CMAP is always studied or always recorded at 2 points of stimulation, one distal and one proximal. Why? I'll come to it a little later. Now, what are the markers that we place once we have recorded the CMAP? On both the traces, that is distal and proximal, you have marker 1, which is the onset of upward deflection. 2, which is the highest point of the upward deflection. 3 is where the upward deflection comes down to the baseline again. 4 is at the lowest point of the downward deflection. So 1 gives me the onset latency. Between 1 to 2 is the base to peak amplitude. Between 2 to 4 is the peak to peak amplitude. And between 1 to 3 is the negative peak duration. I can enter the distance between the 2 points of stimulation and the machine will compute the motor nerve conduction velocity to me. And now since there are 2 sites of stimulation, you can also judge for change in amplitude between the 2 sites of stimulation, change in area between the 2 sites of stimulation, and change in duration between the 2 sites of stimulation. So once again, what does the onset latency tell me? The onset latency tells me the time taken for the nerve to conduct, how much is the delay across the neuromuscular junction, and how much is the time taken for the muscle fiber action potential to develop. So this is the onset latency of a CMAP. But for most practical purposes, we take it as how much time it is for the motor nerve to conduct. So if the onset latency is normal, we say that the segment of the nerve is normal. If it is prolonged, then that segment of the nerve is conducting slowly. So going back to the same example, the snap we saw was slowed. So latency prolonged, conduction velocity slowed. And if you see the CMAP from the same median nerve, you can see that this onset latency when recorded from the wrist is also prolonged. So now this becomes a right median sensory motor neuropathy. Initially, it was only sensory neuropathy. Now we have the motor fibers also coming into it. Okay, focal myelonopathic site of involvement likely to be in the wrist to finger region. Now, why do we require 2 points of stimulation while taking a CMAP? We saw that the onset latency has 3 components into it. One is the motor nerve conduction time, time delay across the neuromuscular junction, and finally the time taken for muscle fiber depolarization to take place. So if I want to judge only the motor nerve conduction velocity, I have to use one more site of stimulation so that all these other factors do not come into play. So that is why you have 2 sites of stimulation and you enter the distance between the 2 sites of stimulation to compute the MNCV. The motor nerve conduction velocity has special significance when you are doing a segmental study. So suppose you are seeing an ulnar neuropathy where you suspect that there is a pressure palsy or there is an involvement around the elbow, which is the common site for an ulnar nerve to be involved. So you can do a segmental study wherein you show that the segments below ME are normal. So the conduction velocity from the medial epicondyle to the wrist is normal. But the conduction velocity above the medial epicondyle to below medial epicondyle, so that segment is relatively slowed. So that is how you localize your site of involvement using your motor nerve conduction velocity. Coming to the CMAP amplitude, the CMAP amplitude tells us how many functioning motor fibers are there, what is the integrity of the neuromuscular junction, and how many functioning muscle fibers are there in the muscle innervated by that motor nerve. So a CMAP amplitude will depend upon the integrity of the anterior horn cell, that is the cell body of the motor nerve, the ventral root or the motor root, the motor fibers within the peripheral nerve, the neuromuscular junction, and the muscle fibers. So any abnormality in any of these levels can cause a low amplitude or an absent CMAP. So if you have an absent CMAP, the site or a low amplitude CMAP, the site of involvement could be at any of these levels. Okay, a small word about how the duration and area changes as we go from the distal stimulation to the proximal stimulation. So this is recording of the median nerve stimulating distally at the wrist, proximally at the elbow. And if we were to see the area, you can see that the area has dropped. From 100%, it has dropped to 90%. The amplitude has also dropped from 8.1 to 7.3. So as we go from the wrist to the elbow, there is a drop in area and an increase in duration. So duration is increased from 100 to 108 in terms of percent. Okay, so there is a drop in area and increase in duration of the response. Why does this happen? This happens because of a physiological phenomena, what is known as the phase cancellation. So every nerve fiber within its bundle will have fast conducting as well as slow conducting fibers. So when we stimulate the nerve distally, the action potential generated by the fast conducting and slow conducting fibers reach the recording electrode almost together to give us a large summated response. But as we move the point of stimulation proximally, now the nerve has to travel or the nerve potential has to travel a longer distance. as a result of which the action potentials generated by the slow conducting fibers start lagging behind. They get out of phase to the action potential generated by the fast conducting fibers, resulting in the summated response being small and dispersed. So that is why at a proximal stimulation, there is a drop in area and an increase in duration of the response. Now, how much of drop in area is normal? Up to 20% drop in area between a proximal and distal stimulation is normal. An increase in duration of about 15% is normal, except for the tibial nerve. But the drop in area is more than 30%. This 30% or more drop in area between the proximal and distal site of stimulation. It is what we call a conduction blocks. So earlier this number used to be 50%. Now the latest EFNS PNS criteria has made it 30%. So even a 30% drop in area and amplitude, provided that your technique is correct, is called a conduction block. And if the increase in duration between the proximal and the distal site of stimulation is more than 30%, then we call it a temporally dispersed response or temporal dispersion. Now, a conduction block is the most common pathophysiology that we see in pressure palsies. Like in the radial nerve, if you have a Saturday night palsy, what you see is a drop in area when you stimulate in the spiral groove. So this is a motor nerve conduction study of the CMAP, which is recorded from the radial nerve supplying the extensor indicis muscle, and this patient came with a wrist drop. So when you stimulate below elbow and just above elbow, you can see that the amplitude is maintained 4.9 to 4.7. But when I stimulate in the spiral groove, the amplitude has dropped to 0.9. If you see the area, there is a drop of almost 84% drop in area, which is very well evident by even seeing the traces. The traces become so small. So this is classically what we see in a conduction block. And the clinical correlate of this will be weakness. If a motor nerve is blocked, your patient has to be weak. So this is a case of Saturday night palsy where you can pick up a conduction block by stimulating the radial nerve in the spiral groove. A small word about the mixed nerve conduction studies. So when you stimulate the mixed nerve, the potential that is recorded will represent the summation of all the individual sensory and the motor nerve fiber action potentials within that nerve. Examples of mixed nerve studies are median and ulnar palmar stimulation, the medial plantar nerve stimulated in the sole. Why is a mixed nerve conduction study important to know is because when you're performing a mixed nerve conduction study, you are stimulating the largest fiber within that nerve bundle. So you're stimulating the 1A fibers, which have the greatest diameter. So they have the fastest conduction velocity. Also, they have the greatest amount of myelin. So in cases of demyelinating disorders, it is this fiber or these nerves which are first compromised. So if you're doing a carpal tunnel syndrome, if you have a patient of a carpal tunnel syndrome, in whom the routine snap is normal, the routine median to D2 or index finger is normal, you can stimulate that patient's mixed nerve in the palm, the median nerve in the palm, and that segment might be slowed because that alone will check the contribution of the 1A fibers. Okay. A small word about the F wave. What is this F wave? The F wave is an artifact which we induce because of our electrical stimulation. So what happens is, if this is my motor nerve, which is supplying a muscle shown in red over here, and here is my point of stimulation. So when I stimulate the motor nerve, the action potential which is generated will travel towards the muscle. That is picked up by the muscle or by my recording electrodes on the muscle as my CMAP or the M response. But in addition to the response going towards the muscles, the action potential also travels antidromically towards the spinal cord. It hits the anterior horn cell, and once again it's transmitted back by the same nerve fiber to the same muscle. And now this will show me the F response. So the F response is not a physiological response. It is just an artifact because of the electrical stimulation that we have given the nerve. these are the parameters which you can assess in an F wave. The most commonly one or the most useful one for most routine purposes is the minimal latency. So the minimal latency is the onset latency of the earliest F wave seen in a cascade of around 10 to 12 responses. A brief about the H reflex. So the H reflex is most commonly measured from the gastrosoleus muscle, and it is the electrical analog or the electrical counterpart of the ankle stretch reflex, wherein the hammer is replaced by the stimulator and we are bypassing the tendon and directly stimulating the nerve. So the pathway of the H reflex is same as that of the tendon jerk. The afferents is the group 1A sensory fibers, synapse is the spinal cord, and efferent is through the motor fibers. So in addition to your soleus muscle in your foot, you can also measure the H reflex from the FCR muscle in the upper limbs, flexor carpi radialis. What are the parameters assessed in the H reflex? You have the onset latency and you have the peak-to-peak amplitude. Okay. Now coming to why should you perform a nerve conduction study? The first one and the most obvious one is obviously to localize the site of involvement, to identify the pathophysiology, whether it is axon loss, whether it is demyelination, to judge how severe it is, to assess for subclinical involvement, to be able to prognosticate and maybe point towards the etiology. So let's see the first one. How does NCS help us localize the site of involvement? We'll begin with the snaps. This is the normal pathway for any sensory conduction. So from the sensory nerve ending in the skin, it goes through the nerve to your DRG, then enters the dorsal root and finally into the dorsal horn of the spinal cord, and then is transmitted upwards to the cortex via the tracts. But a snap will assess only the part which is shown in red. So a snap is going to assess only the DRG and the sensory nerve till its sensory nerve ending. So any pathology which will involve the LMN motor pathway. So if your anterior horn cell is involved, if your neuromuscular junction is involved, if your muscle is involved, your snap obviously has to be normal. But more importantly, the snap will also be normal in cases which are preganglionic or which is proximal to your DRG. So in cases of radiculopathies, in case of myelopathies, even though the patient might have profound sensory symptoms, when we perform a nerve conduction study, the snap essentially has to be normal because the site of involvement is preganglionic or the site of involvement is proximal to the dorsal root ganglion. So this is one fundamental by which we can localize the site of involvement by measuring one snap. My snap is normal, either the patient is normal or the site of involvement is preganglionic. Same thing. So if my snap is normal and the patient has normal sensations, obviously there is no lesion and everything is all good. Now, if my snap is abnormal and the patient has abnormal sensations, the site of involvement is postganglionic, that is distal to the DRG. But if the patient has abnormal sensations and my snap is normal, then the site of involvement is preganglionic, that is proximal to the DRG. Now, if my CMAP is abnormal, then as I said, the site of involvement could be at any of these levels, either at the anterior horn cell, either at the motor root, the motor nerve, the neuromuscular junction, or the muscle fiber. So how do we localize it then? Let's take it one by one. If my snap is normal and my CMAP is normal, I can fairly say that there is no lower motor neuron involvement. Nerve conduction studies can localize the site of involvement only along the lower motor neuron pathway. It has got nothing to do with anything above the spinal cord. Let's take the second one. Now, if my patient has sensory or sensory motor symptoms and my snap is normal, my patient has sensory symptoms, snap is normal, my site of involvement has to be preganglionic. The CMAP in this case may be normal or abnormal. So if the site of involvement can either be a radiculopathy it could be a myelopathy. If I suspect it could be a myelopathy, I can in addition do an SSCP to check the posterior column conduction. Third one, if my patient has sensory motor symptoms and both the SNAP and CMAP is abnormal, then my site of involvement is postganglionic. So it either may be the plexus or the peripheral nerve. And in this case, and in addition, I might have to do the EMG to assess the exact site of involvement, to see how the extent of involvement, to check for innervation, etc. And coming to the last one, if my patient has pure motor symptoms, then I obviously expect my SNAP to be normal, my CMAP to be abnormal, and the site of involvement could be at the anterior horn cell muscle, less likely at the neuromuscular junction. And to further differentiate between these three sites of involvement, I have to use needle EMG or special tests like the repetitive nerve stimulation test. Now coming to pathophysiology, how do I know whether the nerve is into axon loss or it is demyelination? So as we said, if the amplitude of the SNAP or CMAP is low, we know it is axon loss. Whereas if there is increase in the latency, slowing of conduction velocities, if there is conduction block or temporal dispersion, then these point towards demyelination. Now that said, I would like to give a disclaimer here that if the demyelination lasts for a very long time or the demyelination is very severe, it will go into axon loss one day. Also, when the nerve is into axon loss, because the fast conducting fibers are lost, the nerve will show some amount of slowing. So everything has to be taken with consideration about what is the most predominant change that you can see on the NCS picture. Okay, now does NCS alone suffice? So for pure entrapment neuropathies or pressure palsies, nerve conduction studies remain the mainstay of diagnosis. However, EMG may be required to assess for axon loss. For cases of peripheral neuropathies, be it due to diabetes mellitus, Hansen's, AIDPs, CIDPs, hereditary disorders like HMSNs, in these also NCS remain the mainstay of diagnosis. However, if I have to establish the temporal profile, whether it's an acute neuropathy, whether it's a chronic neuropathy, then I have to see whether the motor unit potential has been remodeled. So for that, I require to do the EMG. If my site of involvement or my clinical suspicion is radiculopathies, anterior horn cell lesions, motor neuron disease, myopathies, EMG remains my mainstay of diagnosis and NCS can only point towards my localization. For neuromuscular junction disorders like myasthenia gravis or the Lambert-Eaton syndrome, a special test called the repetitive nerve stimulation test, it is the mainstay of diagnosis, and EMG is mainly used to rule out other differentials. I'll end with this, which I think is very less stressed upon or not enough stressed upon at least. So what is the most important aspect or most important component when you're performing a nerve conduction study? Is it recording of the SNAP, the CMAP, or the responses like the F wave or the H reflex? Whatever the textbook says, the most important component is the clinical examination. And an electrodiagnostic testing can only be an extension of your clinical examination and it cannot replace it. My final slide, a thorough neurological evaluation and a good referral note. These are essential for an optimal nerve conduction study. So if you're doing the nerve conduction study of your patient, you should have evaluated your patient clinically before and you're sending him to a neurophysiologist. Please send a good referral note so that I know what you want me to look into. The nerve conduction protocol must be based on the patient's symptoms. So your protocol or the nerve that or the study that you're performing has to be customized for that patient under study. And the weakest nerves and muscles must be examined. A nerve conduction study alone rarely suffices, and it must be followed by needle EMG or other special tests in order to establish a correct electrodiagnostic impression. Thank you.
Very interesting and informative talk. on this NCS. You have tossed those most basic parts of the NCS. I hope our participants must have enjoyed and must be have some clear knowledge about what is NCS, what's the indications, what fundamentals, how to differentiate between sensory nerve and motor nerve deficits. So let us see if there is any question in the chat box. We'll go through that.
Sure, sir.
Yes, there are some questions in the chat box. Let's start. Which one will be the, I'm sorry, so I have to start from 0. If temporal dispersion is normal,
Temporal,
dispersion is normal.
so we call it temporally dispersed when the increase in duration is more than 30%. So temporal dispersion, increase in duration more than 30%, the term given is temporal dispersion. So if it is up to 15%, it is suppose it's absolutely normal. So when you go from a distal to a proximal site of stimulation, the duration is going to increase. It is going to show a dispersion. Up to 15% is normal. If it goes beyond 30% is when we call that the nerve is becoming demyelinated, or that segment is becoming demyelinated. So temporal dispersion is a sign of multifocal demyelination.
Which one will be more accurate between antidromic and orthodromic?
No, there is no more accurate. It is upon which technique you're following, as long as you're following the normative data for that technique. There are certain inherent differences between the two. As long as you're aware of that and your technique is perfect, both are normal. But antidromic is more internationally accepted.
Another question, can EMG give final diagnosis to a disease?
That is a very vague, in most lower motor neuron involvement, NCS and EMG should be able to give you a site of involvement. It will not give an etiological diagnosis. As in, I can tell you the site of involvement is the muscle. I will not be able to tell you whether it is a limb girdle dystrophy, or whether it's a dysferlinopathy, or whether it is a congenital myopathy. I can only point towards the etiology. So yes, I can give you a site of involvement. I can give you the extent of involvement, but may not be the genetic picture, obviously.
Yeah, pathology cannot be explained here. Yes, one more question. Can you explain inching in technique in future? I don't know about what is that.
Inching, yes. So inching, yes, that inching techniques are basically used when you want to study small segments of the nerve. So if your routine nerve conduction studies are normal and you're suspecting an ulnar neuropathy, and because the ulnar nerve is more commonly affected around the elbow or the medial epicondyle, we inch the nerve. So we study the nerve at distance of 1 centimeters or 2 centimeters. So they're basically short segmental studies. So we do it for ulnar neuropathies. We sometimes do it for a carpal tunnel, sometimes for a tarsal tunnel syndrome. I will try to explain inching. Yeah, but it was beyond the scope of a basic NCS. It comes into a little advanced NCS.
Can you use NCS if you have implant in situ? Is there any chance of interference when implant is there?
Implant by implant, I think it's a pacemaker, because
no, it may be plate, even plate, screw.
No. Plate screws, no problem at all. But for pacemakers, of course, the latest pacemakers are all compatible, but I still like to get a cardiology clearance before I do a nerve conduction study.
Okay. Is it mandatory that if somebody is having pacemaker?
It's not mandatory, but I just like to do it for medical legal purposes, very honestly. Because the pacemaker also works on electrical stimulus, so that is why the old pacemakers were not very compatible, but this is very, very old pacemakers. The new pacemakers are all good. So only thing you have to take care is you do not stimulate very close to your thoracic area. If you're doing a very peripheral nerve, they usually do not cause any problem in when you have a cardiac pacemaker. But other implants, absolutely no problems.
One query from one participant: what would you suggest for study of diagnosis test and interpretation? Do you have any specific books for a suggestion?
Specific books, one of the standard textbooks that is followed is the Preston Shapiro. That is an international textbook. You have the Kimura sir's book. Indian textbook, so you have a very good textbook by Dr. Mansukhani. It's called the EMG Simplified. So that is the Indian textbook you can refer to.
Is there any
And you have
normal
Kalita
range?
Mishra. Sorry, sir.
Is there any normal range for amplitude or latency for a specific node, or does it vary from person to person?
No, you have normatives for every nerve. In fact, now you have 8 stratified normatives, because obviously the nerve in an 80-year-old person is not going to conduct the same as in a 20-year-old person. So normatives have now become 8 stratified. So you have normatives for every nerve. It does not vary from person to person. You have a range. Like if I tell you that the CMAP amplitude for a median nerve, my normative is 8. Suppose if I say the amplitude is 8, then if the amplitude measure is below 8, then I call it abnormal. Obviously, it will vary from person to person. Your median CMAP will not be the same as my median CMAP, but what we are looking at as is normative, the range of normative.
Suppose we are suspecting a traumatic nerve injury, is the ideal time to conduct a NCS after trauma?
Okay. So the nerve, you have, if you want a complete NCS EMG report, then the snaps in case of trauma fall after around 9 to 11 days, and CMAPs fall about 5 to 8 days. And EMG changes usually set in after 3 weeks. But this is in case of a brachial plexopathy. So if I've cut my nerve at the wrist, to study my muscle over here, I need not wait for 3 weeks. So it also depends upon where your nerve is cut. So you can go by the judgment that the nerve will degenerate or regenerate in 1 inch a month. So you can, if my nerve is cut over here and I want to study this muscle, you see 1 inch a month. So I can get a fairly good report within 2 months or something like that. But that said, now people also want early studies because they want to document it for medico-legal purposes so that they're not sued later on. So if I do studies, even say day 2 after trauma, because the doctor just wants that, yes, that the patient is weak and there is no movement. But very roughly, if you can, wait for 21 days.
Since of the chat box, and we have also come to the end time allotted for us. So thank you very much, ma'am. Talk was
Thank
very
you.
interesting. We have a large number of participants, maximum, it was crossed more than 80. So hope all our participants have enjoyed the talk. They have received some basics of this NCS. Almost most of our friends also doing on interpreting this NCS and EMG things. So hope we'll have a few more lectures on this in future. Probably going to finish.
Most definitely.
So thank you very much. I must thank from my core of heart that with our request, you have accepted our invitation, and I don't request you to accept the invitation and present the talk so nicely. And I must thank all participants who have participated in this webinar. I must thank all the office bearers of IAPMR, the PR team, for giving us the platform for conducting this webinar. Also, this webinar is uploading them in the YouTube so that students can utilize it later on also. And I must thank my friends, my colleagues, my PG students of my department for supporting me for conducting this webinar. Thank you. Thank you very much, ma'am.
Thank you so much. The pleasure and honor is all mine.
Thank you. We close the seminar here. Thank you.